Good day, everybody. My name is Erik Hensen. I am an ENT surgeon at the Skull-Based Center in Leiden, in the Netherlands. And together with Annemijn, I would like to talk to you about non-invasive therapy for children with NF2. Annemijn and myself, we have no relevant financial relationships with the products described in this presentation. We would like to talk to you about treatment options in children with NF2, non-invasive therapy for children with NF2, and specifically Bevacizumab, what is known about Bevacizumab in adults, and then we would like to present you the results in children and come to some conclusions. Now, the average age of onset of NF2 is actually not at the pediatric age. It's 18 to 24 years of age. However, 10% of NF2 patients is diagnosed before the age of 10. Unfortunately, the younger the patients, the more severely affected in general, which means that younger patients tend to have higher numbers of tumors and faster growing tumors. Now, there are several management options in children with NF2. These management options include surgery, radiotherapy, and observation or wait and scan policy when the disease is closely monitored and an intervention is only performed when needed. Each of these treatment options has their own advantages and disadvantages. With surgery, for instance, tumors can be removed or partially removed, but surgery can be invasive, and especially at the pediatric age, and it has surgical risks. With radiotherapy, tumor growth can be stopped, but tumors in general do not disappear, and radiotherapy also has its own risks. An important risk of radiotherapy, especially in young patients, is that irradiation might change tumors into more aggressive tumors or cause new tumors to arise. Observation of tumors has, of course, the benefit of not having to undergo surgery or radiotherapy and therefore do not have surgical or radiotherapeutical risks. However, with observation, of course, the tumor is not removed and it might continue to grow. Observation is therefore not always possible. A fourth option is a non-invasive treatment option with a medication. It has been on the market for a few years now, and many of you will have heard about it or even used it yourself. The medication I would like to talk to you about is called Bevacizumab, and sometimes it's better known by its brand name, Avastin. Avastin is a kind of targeted therapy. It is a so-called VEGF receptor inhibitor, a very complex name, but it works by blocking the formation of new blood vessels. Tumors need blood supply and blood vessels to grow, and by cutting off this supply, bevacizumab can slow tumor growth and sometimes even shrink the tumor. Bevacizumab is used specifically to treat schwannomas because unfortunately it is not effective against other types of tumors associated with NF2. Bevacizumab is intravenous therapy. It is administered in hospital once every 2 to 3 weeks. Now, what is known about bevacizumab? The most things that we know is coming through results in adult patients. We know that in adult patients, it has a beneficial effect on tumor growth. The target tumor can be stabilized or even shrink in 91% of the patients, which is actually a good success percentage. There's also a beneficial effect on hearing when the target tumor is a vestibular schwannoma. Hearing is stabilized or improved in 90% of adult patients. However, frequently there are side effects in 94% of patients. And the side effects you have to think about are high blood pressure, protein in the urine, but there are many, many, many more side effects. We also have some children as patients with NF2, and we were interested in bevacizumab in children with NF2, but before we were to perform this therapy in children, we would like to know what is actually known about this therapy in children. Is it equally effective in children? Is bevacizumab safe in children? And what does the literature tell us? And Annemijn Tops has done this research for us, so I would like to ask Annemijn Tops to share her insights.
Thank you, Erik. So when we looked at the existing literature, we found 465 articles on NF2 and bevacizumab. After excluding the duplicate articles and the articles that were irrelevant to answer the questions mentioned before, we found that only 17 of them specifically discussed the effects or side effects of bevacizumab in children. 7 other articles reported outcomes for both children and adults treated with bevacizumab. However, these studies combined the results of both groups and did not provide separate data for children. As our analysis specifically focused on children, we were unable to extract the relevant information from these studies, and therefore we had to exclude them from our analysis. Together, these 17 studies included a total of 62 children, aged between 10 and 18 years. So to date, these 62 children represent the only pediatric patients described specifically in the available research on this topic, which is a very small number. In addition to the small number of patients, the studies showed considerable variation in several aspects, including treatment duration, dosage, disease severity, and evaluated outcomes. For example, treatment durations ranged from as short as 3 months to as long as 9 years, and the patient group included children with both small and very large tumors. This makes it more difficult to compare the data across the studies. Furthermore, not all studies reported on all the outcomes we were interested in. Fortunately, tumor growth was assessed in all patients. Hearing response was described for 45 of the children, and a few studies also provided information on changes in symptoms during treatment. However, side effects were only reported in some studies comprising 28 patients. This is particularly unfortunate, as understanding the side effect profile is crucial for evaluating the safety of this intensive treatment in children. Nevertheless, we carefully reviewed and combined the findings from all the studies to extract the most consistent and relevant insights. We will present the key conclusions in the next few slides. Similar to what has been seen in adult patients, bevacizumab also showed a beneficial effect on tumor growth in children. In 11% of cases, the tumor actually shrank during treatment. And for the majority, around 70% of patients, the tumor remained stable, which is already a meaningful outcome in a condition where tumors typically grow over time. Only a smaller group experienced continued tumor growth despite treatment. These findings suggest that bevacizumab may not only help to slow or stop tumor progression, but in some cases even reduce the size of the tumor. In addition to the effects on tumor growth, several studies also found a positive impact on hearing. In this group, 33% of children showed an improvement in hearing, while 60% experienced no further decline, which is an encouraging outcome, given that hearing loss is often progressive in NF2. Only 7% of patients had a worsening of their hearing during the treatment period, suggesting that bevacizumab may stabilize or even improve hearing in a significant number of cases. The studies did measurements like tumor size or hearing tests. Some also focused on how patients were feeling. In total, 29 children were included in studies that reported on subjective symptoms and complaints. Among these, 1 patient experienced a reduction in pain and about 21% reported an improvement in tinnitus. For the remaining patients, no significant changes were noted, but their condition remained stable during the observation period. This included stability in neurological exams, overall quality of life, and tinnitus-related symptoms. So yet again, while the improvements were limited, the fact that many children remained stable can also be seen as a positive outcome. On the downside, side effects were relatively common in the studies we reviewed. In total, side effects were reported in 28 patients with a total of 13 adverse events. The most frequently reported issues were high blood pressure, menstrual irregularities, and nosebleeds. However, other types of side effects were also noted, including fatigue, protein in the urine, and delayed wound healing. Most of these side effects were considered mild to moderate and could be managed without stopping the treatment. However, in 2 cases, 7%, the side effects were severe enough to require discontinuation of the treatment. Treatment had to be stopped due to high blood pressure in 1 patient and osteomyelitis, which is an inflammation of the bone, in another.
Thank you, Annemijn, for sharing your results on bevacizumab in children with NF2. In summary, I think we can conclude that it seems that bevacizumab is effective in children with NF2. It is as effective as it is in adults. Like in adults, it targets schwannomas only, but it is safe in children too, although there are side effects. And in children too, treatment stops or pauses may be necessary because of severe side effects. So it still is not an ideal solution. I think we also have to conclude that today still there's only a limited number of children described that are under bevacizumab therapy for NF2. And really more research is needed to gain better insight into bevacizumab effects in children. I would like to thank you for your attention on behalf of the whole NF2 team at the Leiden School-Based Center. Thank you.